Hello, my name is Maud Williams, and I am a student in the Psychiatric and Mental Health Nurse Practitioner program at Eastern Kentucky University. Today, I'm going to be discussing an integrative review of the literature for the implementation of cognitive processing therapy for PTSD symptom reduction in adult patients. Mental health illness, such as PTSD, is among the highest with debilitating effects and/or premature mortality in the United States. The National Institute of Mental Health Illness states PTSD affects 3.6% of the U.S. population. This translates to 8 million U.S. citizens diagnosed with PTSD in a given year. The American Psychiatric Association has found 1 in 11 people will be diagnosed with PTSD in their lifetime, and of those diagnosed, only a few will actually seek treatment. The lack of intervention and failure of treatment compliance can potentiate suicidal ideation and/or the act of suicide. To improve the health outcomes of those with PTSD, the advanced practitioner must identify the barriers to treatment compliance and implement evidence-based symptom reduction interventions. When looking at the evidence, questions began to arise such as, what treatment interventions are most effective for patients with PTSD? And how long does the cognitive approach treatment need to be before symptom reduction can occur? Applying Aaron Beck's cognitive theory of restructuring has been proven effective in the treatment of PTSD. Cognitive restructuring, also known as cognitive processing therapy, is a one-on-one approach that takes a patient's misconceptions of reality and forces them to challenge these idiosyncratic ideas and reframe their thought process. Loosening the grip of the patient's distorted ideation empowers them to develop a realistic perspective of life. Empirical evidence thus supports the implementation of cognitive processing therapy as derived from Aaron Beck's cognitive theory of restructuring to decrease PTSD symptoms in adults. Cusack et al. In 2015 conducted a Level 1 systematic review and meta-analysis of psychological treatments for adults with PTSD. There were 64 randomized controlled trials assessed, and all participants were adults within a mean age of 30 to 40 years, all with a diagnosis of moderate to severe PTSD. Major variables consisted of cognitive therapy and its effects on PTSD symptoms in comparison to the inactive or no treatment control group. Resick et al. In 2017 conducted a Level 2 longitudinal randomized controlled clinical trial to assess the effect of group versus individual cognitive therapy in active duty military service members suffering with PTSD. There were 268 participants, predominantly male, all approximately 33 years of age, English speaking, and active duty service members. All were randomly assigned to 2 intervention cohorts. One cohort was individual cognitive processing therapy consisting of 2 60-minute weekly sessions for 6 weeks. Cohort 2 was group cognitive processing therapy consisting of 8 to 10 participants completing a 90-minute weekly session for the same length of time as the individual cognitive therapy group. Dondonville et al. In 2016 conducted a mixed methods quantitative and qualitative study of the effects of cognitive processing therapy on PTSD symptoms in active duty service members. This study used the theoretical framework of cognitive restructuring by Aaron T. Beck. There were 63 participants drawn from 2 randomized controlled trials of cognitive therapy, predominantly males, English-speaking, and active duty service members. The first clinical trial was cognitive therapy in a group setting, while the second clinical trial was cognitive therapy in a group compared to individual setting. The study was also conducted over a 12-week period, and each participant had to write out an impact statement before and after treatment. The value of these studies for nursing practice are evident in the results and support implementation of cognitive therapy for PTSD symptom reduction. The Level 1 study conducted by Cusack in 2015 found cognitive therapy intervention moderately favorable in improving PTSD symptoms in 4 trials, as evidenced by a standard mean difference of p equaling negative 1.99 to p equaling negative 0.67. The Level 2 study conducted by Resick in 2017 found individual cognitive therapy more efficacious than group therapy at reducing PTSD severity, and this was evidenced by a large effect size in post-traumatic stress scales equaling Cohen-D of 0.6 and 0.4 versus the group Cohen-D of 0.7 and 0.6. The qualitative study by Dondenville et al. 2016 supports the use of cognitive therapy in decreasing PTSD symptoms as well, and this is evidenced by a change in percentage of decrease in assimilation and over-accommodated statements, as evidenced by a p-value of 0.0001. The advanced practice nurse could implement cognitive therapy as a one-year program. The treatment should be individual sessions, approximately 60 minutes in length, once a week. To measure the effectiveness of the outpatient treatment, the advanced practice nurse should use evidence-based scales such as those mentioned in the studies. Qualitative results could be measured by using personal written accounts by the patient. Because the primary population aggregate is rural, the chosen setting for implementation would obviously need to be outpatient clinics. It is a national priority to improve mental health services for all. PTSD is among the highest with devastating effects if not treated. Review of the literature identifies cognitive processing therapy as an effective treatment in decreasing PTSD in adults. Study results support the use of CPT for PTSD symptom reduction and thus give the advanced practice nurse the confidence to apply it to clinical practice in the rural outpatient setting. Thank you for your time. If you have any questions, please feel free to email me. I look forward to the upcoming comments in our discussion board.